So, thank you for having me back at the Victory Men's Health podcast. This is my third podcast here, and a couple of days ago, I received a message from Amy asking me to make a podcast about estrogen. And I wouldn't say that I'm sick of talking about estrogen, but I'm a little bit sick of talking about estrogen. But the reason why I'm a little bit sick of talking about estrogen is because it is by far, the most contentious, the most argued, the cause of the most tribalism in the space, and probably the most misunderstood topic in all of men's hormone replacement therapy. So, what I'm going to do today is summarize as best as possible and as efficiently as possible how this process works and what you should do about it. So, I think there are two tribes in this debate, and I think it's very strange that people become tribal about this, but it's definitely happened. This is undeniable. If you go on YouTube or forums, there's very clearly a very hostile divide between these two camps and viewpoints. And the extremes of these viewpoints is one is that you should never test estrogen. It doesn't have anything to do with anything. There's absolutely no problem with as much estrogen in men as possible. And then the other side of the camp is that estrogen is the devil. Estrogen is the worst thing for men's health. Regardless of your levels or symptoms, you should at least modulate it with some degree of inhibition of aromatase. And these camps have caused a very large amount of confusion in patients all over the world. Because when someone first experiences a side effect on TRT, especially when the treatment's starting, in the first 8 weeks, the immediate mental connection between side effects and root cause is it must be estrogen. And there is some truth to this, kind of. Estrogen is often involved in the process of the side effects, but it is not the root cause, and it is not the thing that needs to be blocked to resolve the side effect. And I think that this is where the problem happens, because one side of the fence goes, hey, your side effects are not related to estrogen, don't even look at estrogen, don't block it, it doesn't matter. But this creates a problem of being like, but I have these issues, and if it's not estrogen, then how do I fix it? So people end up between these two camps because maybe they try the estrogen blocker and it doesn't work because they don't work for anyone. I don't think anyone should take an aromatase inhibitor. But then they end up in a camp being like, well, blocking estrogen doesn't fix it, but how do I actually solve the problem? Because neither of these two sides of the camp have actually offered me a solution that works. So aromatase inhibition, I believe, has stemmed and flowed in from bodybuilding. And when men are taking very large, what we call supraphysiological doses of testosterone and other anabolic steroids, depending on the composition of the steroid cycle structure, and this is not really my field, but they may believe or may have benefit to also add in an aromatase inhibitor. None of this is healthy. So I would argue that you're kind of picking your poison. It's like arguing, is it better to drink a bunch of vodka or drink a bunch of whiskey? It's like probably neither. But what has happened as a result of a lot of people migrating from the bodybuilding anabolic steroid space, both practitioners and patients, into the TRT space, is this very pervasive myth that when you're on testosterone, you have to block or regulate or at least partially block the amount of estrogen that your body aromatizes from the testosterone replacement therapy that you're administering. This is a pretty flawed myth, and there's a lot of holes that you can poke in this. It's very simple. One, if you're taking the physiological amount of testosterone that your body needs to thrive as a healthy man, why does that create the need for you to block one of the metabolites of this hormone? In what other form of hormone replacement therapy do we have to co-administer a pharmaceutical medication to block the metabolism of the hormone that we're putting in. We don't have to do that with thyroid, we don't have to do that with melatonin, we don't have to do that with DHEA, we don't have to do that with progesterone in women. Why do we have to do this with testosterone? Why is testosterone this unique hormone that we have to block one of the metabolites of it for it to work properly? That doesn't make any sense. The next myth busting aspect of this is, well, if that's true, then how come all the healthy young men with these optimal testosterone levels naturally, why don't they need to block their estrogen? Because if we're giving you the healthy amount of testosterone that you should have, then how come the guys who don't need to take it exogenously, the guys who make it naturally, the guys who we're more trying to replicate the function of, how come they're doing okay without blocking estrogen? Doesn't make any sense. The other thing that's important to recognize, and this is kind of like, well, we can theorize that the sky is green or the sky is purple, but if you go outside, I can tell you right now it's blue. Find me someone who has blocked their estrogen on TRT who doesn't have any side effects, who actually feels good. Because what I see is guys all over the internet, always in my messages, a lot of the time coming through my clinic or coming to see me for consultations, and I know Victory have the same thing going on, is that guys end up in this inevitable goose chase of finding the non-existent Goldilocks zone between the optimal inhibition of estrogen production and the optimal amount of testosterone. And they are forever tweaking their doses of both to try to find the level that makes them feel good and doesn't cause side effects. And the problem is that it doesn't exist, because aromatase inhibitors cause side effects in all doses in men and women who use them. So a lot of the benefits of testosterone come from the metabolism to both dihydrotestosterone, which is via 5-alpha reductase, as well as estrogen via the conversion to estrogen from aromatase. And then estrogen further metabolizes into estrone and estriol. So there's 3 estrogens. Estradiol, which is what we typically look at, is E2. So there is a really important synergy and balance that occurs between testosterone, DHT, and the estrogen, as well as the metabolites of DHT and estradiol as well. There's this multifactorial balance that occurs, and this balance is shifted based on the inflammatory state and the metabolic state of the body. So in a situation where someone does have elevated estrogen production, this is because estrogen is increased in situations of inflammation. This is because estrogen is protective. So it's kind of like if you've got a house and the smoke alarm is going off, is the solution to turn the smoke alarm off because it's annoying you? Or is the solution to go, hey, why is that smoke alarm on? Maybe I should put out the fire if there's a fire going off? That's the better solution. If someone has got what we call estrogenic side effects on TRT, there are typically 2 problems that are causing this. One is that the dosing protocol is wrong. And if you're working with a clinic like Victory, this isn't going to be a problem. But if you're coming from another clinic, and when I was in the US, I was in the US last year for the Olympia and the Silverback Summit, and I came out to see Victory Men's Health as well. I was shocked and appalled and truly, truly blown away when I was speaking at the Olympia about the idea of injecting your weekly or fortnightly dose of testosterone over multiple small injections per week, say 2 to 3 injections per week via an insulin syringe. And I could see in the crowd of the practitioners, this was blowing people's minds. And that scared the hell out of me. It seems like there are more testosterone clinics within a 10-mile radius of anywhere in the US than there are in the entire country of Australia or the entire European Union. There are testosterone clinics everywhere in the US, and it still seems that the standard of care is a testosterone injection once a week, or God forbid, once a fortnight. This is like having 6 shots of espresso every few days. It's not going to deliver an optimal result of what you're trying to achieve. Side note, I just got an espresso machine. It's one of the best things I've ever done. So the problem is that when you take a large bolus dose of testosterone, let's say 200 milligrams a week, I'm not even going to talk about fortnightly because that's just insane, but 200 milligrams a week, you're working with a medication that has a half-life, depending on the study, of anywhere between 5 to 12 days. We typically say that it's about a week for enanthate and cypionate. There is some variance there. So what you're looking at, what that means, is that if you inject on a Monday, by the following Monday, you've eliminated half of that medication from your system. So you've created quite a big curve. Now, if we look at coffee, for example, caffeine's got a half-life of 8 hours. Now, I don't know about you, but if I drink this cup of coffee now, coffee at 8:30 in the morning, am I going to have a very steady incline of caffeine effects up until about halfway through the half-life, so 12:30, and then a very gradual drop off towards the 4:30 mark? No. I'm going to get a peak in about 60 to 90 minutes, and then most of the effects of the caffeine have worn off after about 3 or 4 hours. The half-life of the medication and the peak distribution of the medication is not the same. It's not a steady process. So when we're looking at what happens when you take a testosterone shot once a week, you're not getting a gradual incline in levels around Wednesday, Thursday, and then a gradual drop in levels Friday, Saturday, Sunday. And even if you were, that still wouldn't be okay. You're getting a big spike on Monday, maybe Tuesday, depending on your metabolism. And then by the time you've reached that next Monday, you've had a massive, massive fluctuation in levels. And this causes problems. The male endocrine system is not built around a roller coaster of hormones. That's the female endocrine system. I'm not going to make any jokes about that. I'm making a podcast for a company that is primarily run by women. But we do know that the hormone fluctuations in women create quite characteristic behavioral effects, let's say. I'm going to cop some shit for this. But when we look at how the male endocrine system works, we are in a daily hormonal rhythm. We are not in a weekly, we are not in a fortnightly, we are not in a monthly rhythm. We are in a daily hormonal rhythm. So giving us a weekly or fortnightly hormone rhythm doesn't work out. It creates problems. It creates hormone imbalance symptoms. Is estrogen part of this cascade? Absolutely. Does inhibiting estrogen production solve this problem? No. It might put a band-aid on part of it, but it's not optimizing your hormone protocol. It's just garbage. What we have to do is distribute the medication in a way that we get stability. From a clinical outcome perspective, the benefits of hormone replacement therapy are significantly optimized when we have stability. So the way that we solve this issue for most guys, I used to sell mobile phones when I was in university, and this was back when you could actually take the battery out of a phone, back in the good old days. And anytime someone came in with a problem, we'd ask them the same thing. Have you turned it off and turned it back on again? And the majority of the problems when people had issues with their phones could be solved by doing a hard reset, taking the battery out, putting it back in, restarting the phone, problem solved. Software bug. Increasing injection frequency is the turn it off and turn it back on again of TRT. It is. So if you're having issues with these side effects, one of the best solutions, and I think it's a great way to solve this problem before it starts and start with this kind of protocol, is inject as often as you're willing to. And twice a week is minimum, 3 times a week is better. Now, some people prefer to do every other day. I think 3 times a week is better because it's just Monday, Wednesday, Friday. It's the same day, it's a 7-day week. Or if you really want to go all out, you can do daily. Now, at Victory Men's Health and myself as well, we'll often recommend transcrotal testosterone cream, which can be applied twice a day, which is ultra stable, but it also allows you to do more regular administration without stabbing yourself. A lot of the time, 7 injections per week is not viable long term because people get sick of it. But I think 3 injections per week with a little insulin syringe into the deltoid is very, very, very manageable. It's very manageable. If diabetic children can do it multiple times a day, you can do it 3 times a week, especially to get the benefits of stable, optimal testosterone. That's a good deal. The juice is absolutely worth the squeeze. That's a high ROI situation. But we also argue for the case that the transcrotal cream is actually a superior form of testosterone administration because of the increased conversion to DHT, plus the fact that we're not having to metabolize an ester as well. Now, these are not problems with injections. I think that they are just advantages of the cream. And segueing into the topic of the cream, I mentioned there are two causes of these side effects. So this is number one. I'm going to be careful which finger I put down here. So the other cause of side effects on TRT is metabolic syndrome. We can also call this insulin resistance. We can put it on the spectrum of pre-diabetes to diabetes, or we could just use the emotionally cushioned term and call it what it is, which is obesity. And when we're looking at body fat percentages, a lot of people who think they're just a little bit fluffy are actually obese, technically. If you do a DEXA scan, a lot of people who think, oh yeah, I've got a few pounds to lose are technically actually obese. This can be a tough word to hear, but this is what's causing problems. You cannot, and I really want to make this clear, you cannot be obese and inject the testosterone levels of a healthy young man and expect it to work without side effects. That's delusional, right? If you take a Suzuki Swift and put a Ferrari engine in it and it doesn't work out and you're shocked and disappointed, that's delusional. It doesn't make any sense. So we have to look at our health realistically, and we have to look at our TRT protocols realistically. And if you've got some weight to lose, and this is the vicious part of it, is that typically if you've been hypogonadal for a number of years, you probably don't have an optimal body fat percentage, because part of the hypogonadism is not only the behavioral maladaptations, you feel like crap, so you do things that are crap for you to make yourself feel better in the short term, because you're a human. And that's just human behavior. Is it good? No. Is it acceptable in terms of a maladaptive coping mechanism that you've gotten through a period with and now you're looking to make a change? Absolutely. But what we have to recognize is going, okay, I need to fix this. This is the problem. I'm not a genetic over-aromatizer. I don't need to take DIM or calcium deglucarate or a quarter of a tablet of anastrozole twice a week. I need to get to a healthy body fat percentage. I need to get myself to the state of health where I would be making these optimal healthy levels of testosterone naturally if I could. You have to match the engine that you're putting in the car. So if you want to have the optimal, healthiest level of testosterone that can be achieved by a male human, the optimal male human physiology dose of testosterone, you have to be in optimal male health. And that is a body fat percentage under 15%. This is what is driving the majority of estrogenic side effects. And the root cause of it typically is drugs, alcohol, junk food, and not doing enough exercise. It's a combination of one or more of those four things. And the period of adjustment where you realize and go, okay, when I start my treatment, I am going to use this boost in energy, this increase in motivation and drive, this support of my preventing muscle catabolism and burning fat and being in a state where I can restore my health. I'm going to get the results I deserve from the effort I put in, nothing more, nothing less. During that period where you're going to go from 25 to 30% body fat down to 15% body fat when you start your treatment, because you're going to put the work in, you're not going to immediately look for medications that you need to blunt your appetite or stimulants. You're going to work on your diet and your exercise and your daily habits. You're going to learn how to get out of the situation that you got yourself into with hard work and dedication and discipline. During that period, your testosterone dose and your ancillaries for your treatment may need to be modulated. Your dose may need to be reduced a little bit. If your dose is up here and your health is down here, maybe your dose needs to be started a little bit more modestly until your health improves and you can bring your dose up with it. What I have found is working with men who are further off track, because if you're the further you are off track, the more help you need. It doesn't disqualify you from treatment. It just means that your treatment is a little bit more difficult for the practitioner to optimize. Now, you have to do the work as the patient or the client. You have to enter into an agreement where you're going to actually put the work in too, but your practitioner needs to set you up for success. Otherwise, you're going to have problems. So, in the cases where someone is, let's say, doing 3 injections a week, you're still getting side effects, you're still, bloated and sensitive nipples and feeling emotional and you're not feeling well, the solution typically is not to use an aromatase inhibitor. That's going to solve one problem but create more. You're going to have brain fog, you're going to have sore joints, probably actually going to have issues with metabolizing body fat as well. Your libido and erectile dysfunction is going to go to crap. All of these problems are going to occur. The solution is to use the transcrotal 20% cream, because doing a twice daily administration with cream, an increased conversion to DHT, and a corrected metabolism of testosterone to estrogen, a more optimal ratio occurring because it bypasses metabolism in the liver. This is going to allow you to tolerate more optimal testosterone levels while your body fat is still something that you're working on. This is the solution to the problem. If you are not tolerating high frequency injections, if turning it off and turning it back on again didn't solve the issue, the solution is to use the transcrotal cream. I have seen this solve this problem in virtually everyone who has tried it. And this is why I'm such a big advocate for the transcrotal cream, because it's tolerated by people who don't tolerate injections. And a lot of people starting TRT are off track because they were hypogonadal. So using the transcrotal cream, and if your HbA1c is elevated significantly, you may need something like metformin for a period as well, which you can discuss with your provider. TRT will help with insulin sensitivity, but if you do need some more help because you are really far off track, there are medications available to support that, but they work directly with the root cause of what's going on. Other supplements like melatonin can really help with insulin sensitivity as well. And also making sure that your thyroid is optimal and on track. And clinics like Victory Men's Health are able to work with all the hormones in the body, pregnenolone and DHEA as well, which are really important for stress and recovery. And getting your entire hormonal system optimized and stable by an expert practitioner is going to solve the problem. If you think you need an AI to solve the issue, either you're not doing the work that you need to do, or your practitioner doesn't know what they're doing. A good practitioner and a good patient can solve any problem in testosterone replacement therapy without the need for inhibiting aromatase production. Inhibiting aromatase production causes harm, and in physiological doses of testosterone, it is never, ever needed. But people still have side effects, and these side effects need to be taken seriously. They need to be discussed. They need to be resolved. And it is requiring work from both the patient and the provider to get this situation corrected. I hope that helped. I'll see you on the next one.